Hello, my name is Terese Hammond. I'm an Associate Clinical Professor of Medicine in the Division of Pulmonary Critical Care and Sleep Medicine at the University of California, Los Angeles in Southern California. And I'm thrilled to be here with you today. I think these next two sessions are quite an honor to give because these are the final sessions of your board review. We're going to try to pluck out some key points from some of the previous lectures that will give you a source of final studying as you go into your exam. All right, so let's start. Let's start at the beginning. Let's start with sleep. As you know, sleep is essential. It's biologically motivated. It's a very complex behavior. You progressively lose connection with self and environment as you fall deeper and deeper asleep. Now, most adults, as you know, require 7 to 8 hours of sleep per night. In fact, it's really a very small percentage of people, maybe less than 0.5% of people, that have some familial short sleep syndrome. The vast majority of adults require that 7 to 8 hours to be fully rested. Getting too little sleep actually has a lot of implications for health and in fact even survival. If you go for a prolonged period of time without sleep, you start to suffer mental and physical issues, and ultimately patients with familial insomnia will succumb, they will die from lack of sleep. So sleep is certainly essential. As we see in a slide just a few slides away from this, there is a very elegant interplay between the sleep load and the alerting signal that we get mainly from blue light. And we're going to go through that. I think that that's a really key concept. But sleep is dynamic, sleep is essential, and sleep is very tightly yoked to all of the processes of our body, especially the processes the metabolic processes that make homeostasis possible. All right, for you to recall, sleep occurs in cycles. There are about 4 to 6 cycles of sleep per night. Each cycle is about 60 to 90 minutes. They all you enter sleep sort of in the same way through non-REM or stage 1 sleep. In general, sleep is broken into 2 big categories, non-rapid eye movement sleep and REM sleep. Rapid eye movement sleep, non-REM sleep comprises about 75 to 80% of the night, and rapid eye movement or REM sleep is around 20 to 25% of the night. As you'll see, REM sleep stays relatively stable throughout the lifespan, but non-REM sleep can change as we go through our lives. And one sleep is awake sleep with eyes closed. Very chaotic. You can have respiratory inconsistencies as you get sleepier and sleepier. You start to have slower sleep. As you move into N2, you start to see these characteristic EEG findings like spindles and K complexes. And I know that you have a very extensive lecture that goes through EEG interpretation for sleep. Delta sleep or slow wave sleep, N3 sleep is very high amplitude and low frequency. And then finally, at the end of each sleep cycle, you have a period of rapid eye movement or REM sleep. The first 2 or 3 sleep cycles of the night tend to be enriched with non-REM sleep, especially slow wave sleep or N3 sleep. You have small or shorter rapid eye movement sleep periods. The last couple of cycles of your sleep phase tend to be much more enriched in REM. So you see longer periods of REM sleep and much less of the slow wave sleep. And then, just as I was saying, this is just again a little bit of a reminder about how non-REM sleep breaks out. Clearly, it's very high yield for you to go through the EEG patterns and commit these to memory as you get closer to the test. As we sort of talked about in the last slide, I think the key here to realize is that the majority of your sleep will be non-REM sleep. About 20 to 25% of a night's sleep will be rapid eye movement sleep. Now, this is a really cool part of sleep. Rapid eye movement sleep is where we presume that the majority of dreaming occurs. And in order to protect us from injury, actually, during dreaming sequences, there's also a component of REM sleep that causes a virtual paralysis. So when you go into REM sleep, you enter a dream state, you have a virtual paralysis that prevents you or protects you from acting out your dreams. And as we'll see at the end, there are some conditions that can be quite dangerous when they occur when REM sleep is disturbed. Again, these patients are more difficult to arouse. It's very hard to get them awake in the morning when they're in rapid eye movement sleep. If you wake somebody up from REM sleep, they can remember their vivid dreams, and actually that tends to be what happens when we wake up in the morning. We're coming out of our longest period of REM sleep. Again, it's characterized by the loss of muscle tone. You have great variability in blood pressure. You have rapid eye movements, which can be seen, and as you can see on polysomnography. There is a sort of a favorite question, I think, of the board examiners about changes in REM sleep that are associated with major depression, such as decreased REM latency and increased REM density. This, I think, is something that you may want to just file away. And then again, you have a polysomnography that shows characteristic REM sleep with a decrease or flattening of electromuscular activity here in the chin leads. You have these rapid alternating eye movements, and if we could see the EEG tracing a little bit clearer, you would see that the EEG looks much more characteristic of awake than it does of N2 or N3 sleep.